Welcome to our clinical seminar discussing bipolar not otherwise specified in childhood with Dr. Demitri Papolos and Dr. Robert Post. For those of you new to CMHRC, my name is Elizabeth Errico. I am the founder and executive director of the Children's Mental Health Resource Center, where it is our mission to provide guidance and resources for early identification and management of mood disorders, including bipolar disorder and its newly recognized phenotype, thermoregulatory sleep dysregulation disorder, also known as FOH. Our learning objectives for this training are to examine challenges to diagnosis and treatment of bipolar disorder in the pediatric population, to analyze current psychotherapeutic treatments for bipolar disorder in children, to analyze current psychopharmacological treatments for bipolar disorder in children, to describe a newly recognized phenotype for bipolar disorder in children, and to identify, I'm going to read this again. To describe a newly recognized phenotype of bipolar disorder and its biological marker, and to identify a new treatment protocol for bipolar disorder in children, and to address TSDD. There are systemic barriers to treatment for bipolar disorder that encompass age, gender, and race-related issues. In the pediatric population, there are systemic barriers to treatment that involve misdiagnosis or delayed diagnosis. It's estimated that the average treatment onset delay for children with bipolar disorder is 10 years. That's from the time a family identifies their child needs help until an accurate diagnosis and effective treatment plan are put in place. This can be caused by mood swings that are confused with typical developmental behaviors or symptoms associated with more commonly seen diagnoses, such as ADHD. There's also a severe shortage of child psychiatrists who are trained to diagnose bipolar disorder in childhood, and there are also not enough child psychiatrists in the country to meet the need of mental illness in childhood in general. Parental awareness that mental illness can exist in childhood also creates barrier to treatment, as very commonly involuntary symptoms are misunderstood and perceived to be intentional behaviors that require discipline, not treatment. And there are also medication concerns from parents, schools, and practitioners and prescribers about the effect that providing a significant diagnosis may have on a child, not least of which around the side effects of potential long-term medications. Gender-related barriers for women include stigma around mood symptoms that are often dismissed as being hormonal or emotional, or again, as intentional choices. There are reproductive issues that often block providers from being willing to provide women with a diagnosis and appropriate medication during their reproductive years, which can include during pregnancy or breastfeeding, or just during years where in theory they could get pregnant even if they are not planning to. These assumptions can disrupt treatment, delay it, or cause it not to happen at all. Additionally, women tend still to be the ones who shoulder the burden of primary caregiving responsibilities for children as well as other family members, which provides limited time and resources for appointments and consistent care. Gender-related barriers for gender-diverse individuals include things such as discrimination in healthcare settings, which leads to mistrust or avoidance of treatment altogether. There are provider knowledge gaps around issues related to cross-hormone therapy, how it may interact with mental health conditions, or how it may interact with mental health medications. There are also significantly higher baseline stressors for gender-diverse individuals in cases where societal pressures and stigma can worsen symptoms and become an obstacle in themselves to follow through with medical and psychiatric care. Race-related barriers for Black Americans are significant and truly systemic. Misdiagnosis is higher in Black Americans than in white populations, with schizophrenia being diagnosed far more frequently in Black Americans than bipolar. There's also medical mistrust that is rooted in historical and ongoing inequities in terms of access to treatment as well as in the treatment itself. There's also reduced access to specialty care with fewer psychiatrists in predominantly Black neighborhoods and reduced representation in the medical providers themselves. According to the American Psychiatric Association, approximately 2% of American practicing psychiatrists are Black. Race-related barriers for Latino individuals are also significant, with language barriers being a primary obstacle to accessing treatment, with a limited number of bilingual or bicultural mental health providers available. In our current climate, there is also considerable fear around immigration factors. Concerns about documentation, being asked to provide it, or prove their ability to be in this country can deter individuals who need care from seeking it for fear of the devastating consequences if they happen to be undocumented. There's also a lack of cultural competency around mental health care treatment within the Latino community because of gaps in provider knowledge. Many patients within this community prefer spiritual or family-based approaches rather than strictly medically based treatment. And without providers fluent in those approaches, it can deter folks from seeking out treatment. Race-related barriers for Asian American individuals are also significant. The issue of somatization is extremely influential. Providers very often don't realize that within Asian communities, expressions of physical discomforts, complaints, ailments, or injuries can in fact also be representative of emotional symptoms or struggles that the patient may be having. And a lack of understanding on the part of providers leads to delays in diagnosis and treatment for Asian Americans. This speaks to the limited number of culturally competent providers in that few clinicians truly understand the cultural norms around emotional expression, feelings about mental health, and the role that family plays in the importance of a patient's life. For this reason, very often Asian Americans are simply overlooked in the mental health care treatment process. Race-related barriers for Pacific Islander and indigenous communities are also important to recognize. There is geographic isolation for these communities, often with long distances that need to be traveled to care, especially for psychiatric specialists. There's historical trauma that contributes to distrust of institutions, and a severely underfunded mental health care service system in areas that have indigenous communities. For this training, we are going to be focusing on children and focusing on an article that was published this year in April of 2025 in the international journal Acta Psychiatrica Scandinavica. It's called Treatment of Early Onset Specified and Unspecified Bipolar Disorders, a Systematic Review and Strategies for Identifying and Managing a Thermally Dysregulated Subtype in Children. This article was written by Dr. Demitri Papolos, Dr. Robert Post, and Dr. Martin Teicher from McLean Hospital at Harvard University Medical School. Tonight, I'm so thrilled to say that two of these authors are with us. Dr. Demitri Papolos is the author of The Bipolar Child, the founder and director of research at the Juvenile Bipolar Research Foundation, a renowned child psychologist and researcher who discovered the newly identified subtype of bipolar known as thermoregulatory sleep dysregulation disorder, or FOH. Also with us is Dr. Robert Post, practicing psychiatrist who was with the National Institute of Mental Health for 35 years, 20 of those years as the chief of the Biological Psychiatry Branch. His career focused on bettering the understanding and treatment of bipolar disorder, emphasizing the importance of early, long-term treatment to prevent progressive episode recurrence and treatment resistance. Dr. Post is the editor of Bipolar Network News and the author of Treatment of Bipolar Illness, a casebook for clinicians and patients.
Dr. Papolos, Dr. Post, welcome. Thank you for joining us.
Thank you for the invitation.
Thank you.
So what we're going to be speaking about tonight is this paper, which starts off with a discussion of bipolar unspecified, or what used to be called NOS, not otherwise specified. Dr. Post, can you give our audience a little bit of background on what that is and how it presents in children?
Yes, I can. And I want to start with the perhaps startling statement that it's common, poorly recognized, and poorly treated. And it has a double whammy to it because the earlier the onset, the more adverse course of illness into adulthood. And the other thing is the earlier the onset, the more delay to first treatment. And delay to first treatment is another poor prognosis factor. So the key thing, I think, is that we need to recognize BPNOS earlier, and this variant that you'll hear from Demitri, and get it treated aggressively because Boris Bermerher and Axelson at Pittsburgh find that the BPNOS subtype, and that is that you have depression, but only brief bursts of mania, anywhere from hours to a few days, that doesn't reach BP2 criteria or BP1, that is the most common early way the kids present. And if they're followed for another 4 years, 50% of them will convert to regular bipolar 1 or 2, depending on a positive family history. The key thing they found was that it's very difficult to treat. It's difficult to stabilize these kids, even more difficult than bipolar 1 and bipolar 2. And the other thing about this is that it's much more common in the United States than in Europe. And the reason for this is that we have more family history of psychiatric illness and bipolar disorder in the US than in Europe, and we have more psychosocial adversity in childhood than they do in Europe. And those two factors are associated with both early onset and poor prognosis. So the data are quite startling, and the data from our network and the STEP BD network is that a quarter of the illness starts before age 13 in adults with bipolar disorder. So a big hunk starts very early, and then 2/3 starts before age 19. So we're talking about an illness that's of child and adolescent onset and tends to be very difficult to treat. The way most people treat it is with an atypical these days, and we're finding that that's not enough, that lithium, an atypical that's well tolerated, like lorazepam, and then another drug.
Dr. Post, I'm just going to interrupt you for 1 second to clarify what you're referring to when you say an atypical. You're referring to the atypical antipsychotic medication category, correct?
Yes, I am. And in particular, the antipsychotics that have good antidepressant effects, like, for example, Abilify doesn't have positive antidepressant effects, and it has some side effects to it. The same with the risperidone. So if you use a well-tolerated atypical like lorazepam, which is FDA approved for kids 10 to 17, with lithium and with lamotrigine. That's actually got a nickname of triple L therapy. Uh, Lithium, lamotrigine, and Latuda, and that actually stabilizes a fair number of these individuals. And the key thing here is that lithium is increasingly recognized as important for treatment of kids and adolescents. And that's important because Demitri will tell us that lithium is fundamental to his treatment of the temperature and sleep variant. So we have some convergence here that the kids with classic BPNOS who don't have the temperature and sleep dysregulation disorder require very aggressive treatment and often with multiple drugs in combination. So let me stop there for a moment and see if there's any questions, and then we'll start to deal with the temperature and sleep dysregulation disorder as well.
So I'm hoping we can take a step back for a moment and sort of describe what BPNOS looks like in children, because there's a lot of confusion amongst clinicians on how to identify it because there are no diagnostic criteria listed in the DSM specific for pediatric presentation. So how would you as a clinician look at the symptom presentation from a child of, say, 9 years old and identify it as being BPNOS?
Yeah, that's that's a great question, and there's a specific answer to it that you can't look for things that are common to ADHD because ADHD and bipolar are so often comorbid they don't distinguish each other. So you have to look for things that are uniquely bipolar, such as periods of euphoria, brief or extended euphoria, and decreased need for sleep. And when these kids have poor frustration tolerance, they completely lose it. They can get aggressive. Another thing to look for that separates these kids is uh, they can be hypersexual and proposition teachers and other people inappropriately. The other thing is that some of these kids can actually have hallucinations and delusions, and they can have suicidal and homicidal thinking. So those kinds of things need to be specifically looked for because the ADHD kids don't have that. And when we, with Bob Finland, looked at the kids who turned out to be bipolar versus ADHD, we found that a number of distinctions there were recognized early on. When kids were even 3 years old, they had some of these brief bursts of euphoria, decreased need for sleep, and very poor frustration tolerance. So all these things can be picked out as different than ADHD right from the get-go.
So I'm glad that you brought up ADHD. There's a question that came in from the audience that we hear all of the time, and I'd love to hear both of you respond to it, which is, so what's the difference then between bipolar disorder in childhood and the DMDD, disruptive dysregulation mood disorder, disruptive mood dysregulation disorder diagnosis?
Yeah, well, they've looked at this disruption, mood dysregulation disorder, and they find out that it doesn't have any specificity to any childhood illness. It goes with all of them, with depression, oppositional defiant disorder, you name it. So it's not helpful, and it also doesn't have a specific treatment assigned to it. The way Demitri has defined his syndrome, which has a good treatment. So the disruptive dysregulation disorder, it turns out to be not a very useful concept. And instead, one has to look for these kids with bipolar-like mood disorder, and even if they don't have extended periods of mania and just brief intermittent ones, they're in the bipolar spectrum. They actually have bipolar to start out with, and need to be treated aggressively that way.
Dr. Papolos, could you weigh in on this too?
Yeah, well, I would agree with everything Bob said. I would add to it that DMDD is rather an invention of its times. It was during a period of time when bipolar disorder was starting to be diagnosed in childhood, where before it rarely ever was. And the rates over a 2 or 3 year period were increasing to such a degree that people in the DSM mood disorder committee for children felt that there was a lot of misdiagnosis happening, so they wanted to split off a condition that they later called DMDD as the group that was irritable but not euphoric. And that was the way they conceptualized it at the time. And of course, unfortunately, there has been no effective treatment for this conceptual diagnosis. And as time went on, as Bob said, there was no specificity between anything that looked like it, even the oppositional defiant disorder, explosive disorder, that intermittent explosive disorder, other conditions that I think also overlap frequently with bipolar disorder. And I think you have to add to that the long-standing belief by most child psychiatrists that bipolar disorder cannot really be diagnosed until adolescence or later, and then even then it is rare. And that, given what Bob said, most of these children who fall within the rubric of what used to be called BPNOS onset very early on, and in early adolescence and much earlier. So I think those are the things that I would add.
So, what is the youngest age that we could say that we can see symptoms of bipolar disorder in children, or the youngest age we would be able to diagnose? And to what degree does family history play a role in that?
Yeah, the family history is key. It's a major risk factor. And interestingly enough, you should take the family history of the grandparents as well, because that adds an additional risk factor. So family history is important, and one should look out for the illness more often that way. The other thing is if both parents have a mood disorder, it also increases the risk for early onset. And I've seen kids age 3, 4, 5 who have pretty classic bipolar disorder get very depressed and then have mood elevation for a brief period of time, get super depressed again, and are terrors around the house. And family members have said that some of these kids started from the age 2 like this. So it can go very early, and one shouldn't dismiss severe behavior dysregulation as nothing very important at all. It is, and it needs to be treated aggressively.
So now, Dr. Papolos, you and your team, through the Juvenile Bipolar Research Foundation, identified this new phenotype that Dr. Post has referenced that has a thermoregulatory dysfunction. Can you give us a brief history of how that was first identified?
Sure. So it goes back quite a ways. The first child that I treated who was a 5-year-old girl, now more than 2 decades ago. She's recently matriculated from college and is working and living independently, I'm glad to say. In retrospect, she remains one of the most severe cases that I've ever encountered. Um, she suffered from really profound sleep disturbance. She had horrific nightmares and night terrors, marked separation anxiety, rapid and unpredictable mood swings, violent, aggressive outbursts, and most strikingly, this severe thermoregulatory dysregulation, which at the time seemed like a secondary event, but was clearly part of the picture. And her symptoms span the whole entire spectrum of what we later would come to call fear of harm. Um, None of the usual treatments really brought any meaningful relief. And what stood out most clearly were the fear-based symptoms and the temperature dysregulation, and the aggression, which we look at now as really also it's a defensive aggression, and it is out of the feeling afraid and misperceiving events as threatening when they're not, and then becoming aggressive, avoidant or aggressive. So around that time, now we're talking over 20 years ago, there was a series of animal studies that showed two remarkable findings about ketamine. First, that it could be that dose dependently it lowered core body temperature. And second, that it had dramatic effects on fear sensitization and conditioned fear responses. And we were looking for other things we might be able to do with this young lady, and that looked like it might be something that would work. But ketamine had never been used in pediatric psychiatric practice, and it really had rarely been used except in experimental studies at the time in psychiatry. I mean, it was an anesthetic primarily. That's how it was known. So prescribing it directly really wasn't practical. Fortunately, she required dental surgery, and her dentist, who was very familiar with ketamine's use for pediatric anesthesia, agreed to use it. And within an hour of the procedure, this child became calm, well regulated, completely asymptomatic, and the improvement lasted for somewhere between 8 or 10 days. And then she started having these thermoregulatory symptoms. She was sweating all the time. She was overheating and started not being able to sleep at night again. And then the symptoms returned. And so that moment really shaped everything that followed. Um, it, to me, it revealed that targeting thermoregulation and fear circuitry could really transform the illness almost immediately. And that, I would say, that single experience catalyzed the development of what we now call temperature and sleep dysregulation disorder.
And the name of this disorder has evolved, it seems, as the research has evolved, that it was started out being referred to simply as fear of harm. And then the name evolved. It was thermoregulatory mood dysregulation disorder. Then it is thermoregulatory sleep dysregulation disorder. Can you talk a little bit about that evolution of understanding?
Yeah, well, when we realized that it was a cardinal symptom, along with what we call fear sensitization, as the primary underlying phenomena that are going on, and that it and began to research the thermoregulatory system and really learn more about its importance in human behavior. And we realized quite quickly that it is a major regulator of sleep onset and sleep offset, and that it is of critical importance for transitions between REM and non-REM sleep. And so it has a significant effect. And all of the sleep disorder symptoms, the difficulty initiating sleep, getting to sleep, the early insomnia, the many arousals during the night, and the sleep inertia in the morning, as well as the parasomnias, the arousal disorders of sleep, the nightmares, the night terrors, teeth grinding, and other arousal disorders of sleep, which were part of the picture across the board, all could be explained in terms of a dysregulation of body temperature. And in particular, we focused on difficulty dissipating heat from the body. I mean, I'm going to go into a whole lecture on what the thermoregulation and how, but those were the things that led us to understand that this was real, and that it was affecting sleep, and that out of that, these recurrent horrific nightmares that were extremely lucid, and which, when the children were able to talk about them, and certainly adolescents who could retrospectively describe them, they described them as the shark coming at me and biting into my skin, and I could feel the blood coming out of my body. It was extremely vivid imagery, and this was across the board. These children had those kinds of nightmares. So we began to wonder whether, since they recurred at such an early age, and they persisted at least intermittently for long periods of time, whether this imagery was really imprinting, and this was the cause of the fear sensitization that then became prominent during the day, with misperception of neutral voices as threatening, or movements, feeling criticized if someone said something that was mildly, a teacher might, point out something, that there would be a very significant response of feeling threatened or criticized. And so we began to realize that it really shaped the whole psychological profile developmentally as the child grew. And as well as the other factors, the separation anxiety, because many of the nightmares, the content were always about threat, intruder threat, someone trying to kill you, or abandonment by close ones, by parents usually. And so those were the themes that would come up over and over again, and they fit with the general fears that these children would walk around with.
Yeah, and I might add to that
Please.
When I was a novice about this syndrome, I learned from Demitri that you had to ask parents specifically about the thermoregulatory and sleep problems. And in particular, when I asked a series of patients, did the kids have red face or red ears? Did they go outside without a jacket? Did they not want to sleep with pajamas because they were too hot at night? Did they always want a fan or an air conditioning? If you lead in with those kinds of questions, it's surprising that that will lead you into further questions about the sleep dysregulation and the nightmares and stuff. But the key thing is that you have to specifically ask those questions, because the parents won't necessarily recognize those or volunteer those as part of the syndrome. So that's a lead into the syndrome that's critical for parents to ask about.
Thank you for including that, because it is such an important thing when we're talking about treatment and getting it to an accurate diagnosis, the importance of that history, the importance of getting all of the information from the parent going back further than I think what most clinicians typically have time for in their practices, but being able to really put in the time and energy to collect a detailed history of the patient as well as family history, as you said, going back to the grandparents, it can really help to reassure clinicians that they are getting the information that they need to make this diagnosis accurately. Dr. Post, a lot of the symptoms that Dr. Papolos described associated with the fear of harm phenotype are also symptoms that can be associated with bipolar in general. And I'm curious if you could share a little bit of information on, the fact that suppose what I'm asking is a lot of clinicians will dismiss those things as being typical childhood behaviors that could be developmentally expected and could be outgrown, and wondering how you identify them as being part of the bipolar diagnosis as opposed to typical childhood behaviors.
Yeah, it's very often the severity and persistence of these things. The nightmares, as Demitri said, are horrific. The violence and aggression can be something that ruins family life altogether, gets the kid kicked out of school. Those things are not typical. So it's sort of the bipolar not otherwise specified category with this overlay of temperature and profound sleep dysregulation on top of it that gets you to the hint that it requires a different kind of approach to the therapeutics. So it's severity of impact on these kids and for that matter, the whole family.
Dr. Papolos, it's my understanding that from what you've said, that the sort of key differentiation point for this, for these two, for bipolar versus the TSDD phenotype, is this temperature dysregulation piece. That really is the hinge on which the TSDD is identified. Is that correct?
I would say that's the clearest marker. I mean, it has a physiological basis, and the symptoms are observable and pretty clear. It's certainly there's a spectrum. I mean, there are some kids that the minute they move a muscle, they start overheating basically, and some, you see it less often, and it can change over time. But they're I would say over 98% of children that I have diagnosed with that condition have those symptoms. I think the fearfulness, the fact that the sense of they're constantly surveilling the environment for threat, and I mean, if you describe that to the parents, are they always in a fight or flight mode? Is it very easy for them to explode when they feel threatened in any way? They'll answer yes. I mean, that is basically a defining feature. So fearfulness and the fear sensitization is profound. I mean, I think really, and it's not something you want to say to parents, but these kids are walking around terrified most of the time. I mean, they are really in a state of fight and freeze, basically, is the way I would think about it in general. So that's different. I don't think children who have BPNOS and don't have this subtype, I don't think they walk around fearful like that, all the time.
So in your paper that was published in April, and the a link to the PDF of that paper was put into the Q&A, so folks can access it directly. You talked about two main pieces of treatment. You talked about medications, and you talked about psychotherapies that may or may not be effective. Dr. Post, you've talked a bit about the 3Ls. My understanding is that lamotrigine is often used in the context of depressive symptoms that are associated with bipolar. I'm wondering if you could talk a little bit about how you would use medication optimally when the child trends towards mania in terms of the bipolar symptoms.
Yeah. The key thing for mania is lithium, mood stabilizing anticonvulsants such as carbamazepine, oxcarbazepine, not so much Lamictal or lamotrigine, which is a better antidepressant, anti-anxiety agent. So those things, along with atypical antipsychotics, are the key thing for full-blown mania. And if one uses lamotrigine, low doses are adequate for its antidepressant effects, but you need 80 to 160 milligrams higher doses to get into the anti-manic and antipsychotic range. So it's a combination of a number of different meds, and it often requires this combination to really get after them. What was the other part of your question?
About specifically addressing mania in those medication combinations.
Yeah, so we have a lot of good anti-manic drugs, huge numbers of them actually, and that's not so much the problem as the depressive side, and the lamotrigine and the Latuda and the lithium all address the depression as well. So everybody thinks about lithium for mania, but lithium is actually an excellent antidepressant preventer, and it works well in combination with essentially all of the atypicals. The other thing is that if lithium's not sufficient, the people who go up and down real fast multiple times within a day, the calcium channel blocker, nimodipine, actually works very well in those people with multiple rapid fluctuations in mood within a day. And lithium plus nimodipine work better than either drug alone. And nimodipine blocks a specific calcium channel that lets too much calcium influx come in. It's called CACNA1C. And if one has that vulnerability gene, it predisposes families to both depression and bipolar disorder. So lithium can be augmented with nimodipine if needed, but the main things are lithium, an atypical antipsychotic that's well tolerated and has effects in depression. And then the lamotrigine is very effective. If somebody can't tolerate lamotrigine, oxcarbazepine or carbamazepine are very useful. The other thing is if you're using oxcarbazepine or long-acting carbamazepine itself, you can actually give all of that medicine at night at sleep time. So that's another thing that helps people getting to sleep. So long-acting carbamazepine is called Equitro, and long-acting oxcarbazepine is called Oxtellar. And those can be dosed all at night and help a lot with sleep and aggression and mania.
Dr. Papolos, did you have anything you wanted to add to that?
Uh, no, I think in terms of treating the manic symptoms, the only thing I would add is that, and I think it's fairly well known that most of these antipsychotics, atypicals, have side effects, particularly metabolic side effects that, where often there's a lot of weight gain and it can become significant over time. So ideally, if lithium alone or lithium in combination with oxcarbamazepine, for example, don't uh, reduce the cycling. I think nimodipine is an excellent idea. Unfortunately, we have no studies in children on calcium channel blockers that I know of, and it's also scantily studied. There's only a handful of reports about nimodipine, but I think there's so much evidence now coming out of genetic studies. I think the calcium channel that Bob refers to, the particular gene that expresses that calcium channel is the most commonly found associated genetic association in genome-wide study of bipolar disorder at this point. So I think it would be wonderful if nimodipine could be tried in a large sample in some kind of controlled study, because I think it could really be very, very effective with these kids who are, for the most part, ultra rapid cycling. They cycle within the day, so they have a diurnal rhythm, um, which is, I mean, I don't know whether that is a phenomena that we know much about in terms of BPNOS. Do you know, Bob, whether they also cycle very rapidly, the kids that were originally identified that way?
Yeah, they cycle very rapidly, and we've seen ultradian cycling, that is, changes in mood within a day, and actually a fair percentage of adults. I saw one adult person who was cycling 5 times up and down within a day, and that person responded very beautifully to nimodipine. The other thing that you mentioned in terms of side effects of the atypicals, I don't like to use the ones that have big weight gain side effects to them. Lamotrigine, Latuda is relatively weight neutral, and uh, so is lumateperone, and so is the drug called Vraylar. And they are unique in terms of not having huge weight gain, but also they have antidepressant effects built into them as well. So starting out kids on treatments that are not associated with marked weight gain is crucial. There's also a new meta-analysis that says that lithium is not associated with any more weight gain than actually placebo. So lithium is not on a big weight gain spectrum like some of the other drugs.
So, Dr. Papolos, in the paper, you also discussed psychotherapy interventions that have been shown to be useful in kids who have bipolar disorder and TSDD. Can you speak a little bit about what your findings were?
Yeah. So before, I just want to go back briefly
Sure.
and mention that the other thing that we know, because we know about the dopaminergic system, is very, very much involved in thermoregulation. And so treating with dopamine receptor blockers, which these atypicals are, can also really have a significant effect on body temperature regulation, and that's something you want to
Right.
avoid. And if you do start them, then you really should be monitoring that to see if it's actually making the underlying condition worse. And so we can say about serotonergic agonists, any of the SSRIs, anything that increases serotonin in the synapses, the serotonin system is critically important for various kinds of regulations of thermoregulation. So it's another group of medications that you want to really try to stay away from.
Yeah, the
Um,
other thing you asked about is psychotherapy, and I would just add that for the kids who are prodromal, who don't have full-blown bipolar illness yet, Dave Mickelwitz has family-focused therapy working very well, and a number of other people have similar data. So I would suggest that any kid with these premonitory symptoms, depression, anxiety, positive family history, that they have family-focused therapy. And Mickelwitz has found that the ones who have high expressed emotion in the families are the ones who do best. So adding early psychotherapy in and trying to head off more severe illness, I think is a critical early step in the process as well.
Yeah, I think really this was the key message that came out of our review of the literature, that we have really far more evidence supporting psychosocial treatments than pharmacological treatments in these kids. And family focused therapy, like as that David Miklowitz has brought to the field, repeatedly showed significant benefits. I mean, in contrast with pharmacological evidence which was really surprisingly thin, and lithium really stood out as the agent with the strongest long-term data across the pediatric bipolar spectrum. But again, more study needs to be done. But I think the really major conclusion is that family focused therapy is critical and ought to be, a requirement in terms of treating these conditions.
Dr. Post, there's a question that keeps popping up in the Q&A, which is about the safety of lithium. There's a pervasive, I believe, misconception that lithium is somehow inherently dangerous and that taking it is going to inevitably lead to toxicity. Can you address the safety of lithium as a treatment for children?
Yes, you're identifying something that's very pervasive. And in general, the benefits of lithium are neglected and the adverse side effects are overemphasized. And in terms of the side effects you're talking about, this weight neutrality has amazing data on it in terms of meta-analysis, so that's not a problem. The thing that bothers people are the long-term effects on the kidney, and now there's large studies in uh, both Israel and in Denmark that if they follow people who have been treated long-term with lithium versus anticonvulsants or other agents, there's no more kidney dysfunction in the lithium treated patients than there is with these other agents. The one side effect that does definitely show up in a 10 or 15% of people is hypothyroidism. And people say that, that's some kind of lithium toxicity or something, but it's it's not really a problem because the people who get that can have thyroid hormone supplementation. So most of the things with lithium can be handled with uh, with potentially doses that are well tolerated. I give lithium to people at any dose they tolerate. If they have tremor, I lower it below that and come in with other things. Um, so that lithium is actually much better, well tolerated than one would suppose. The other thing is that we need to tell patients all the assets of lithium because they don't know them. Lithium is actually an excellent antidepressant as an augmenter, and on its own, it prevents depression. It's actually one of the best drugs for preventing suicide, and that's an increasing problem in our children these days. It also uh, has positive effects on the hippocampus. It increases neurogenesis. You make more neurons in your hippocampus, and your hippocampus actually gets larger on lithium. And along with that, lithium protects memory. And an interesting thing that nobody really knows about, but I make sure I tell every patient, is that lithium actually adds DNA to the end of your telomeres. Those are the end strands of your DNA, and if they get too short, you're prone to all kinds of physical and medical illnesses and mental illnesses. Lithium puts the DNA back on them and increases good health. And the other thing is that people on lithium um, actually live longer. They have decreased all-cause mortality than people not on lithium. And they've just done a study that if you use lithium only intermittently here and there, it doesn't work any better than on no lithium at all. So if people go on lithium, they should go on it and stay on it. And there's lots of good things that happen to the brain because of lithium, including more new neurons, hippocampal volume, decreased suicide, length of telomeres, and people need to have a more balanced view of that.
Um, Dr. Papolos, did you want to add anything to that about the lithium?
No, I totally agree. I think Bob has given a very good summary of some of the um, important aspects and salutary benefits of lithium. Just to add, although it's sort of I guess unstated, that when it's being used in some geriatric settings as for treating dementia because of the increase in its ability to generate new neurons. Uh, so and that uh, there are just a lot of benefits to lithium. The one thing I would add actually is that this really pervasive negative rap that lithium gets and toxicity is always raised as an issue. And the toxicity that's being described is essentially kidney toxicity, renal toxicity, which, as Bob described, it's no significantly different with lithium than it is with anticonvulsants. um, but it really weighs against using lithium as a treatment because even if an individual clinician is willing to use it in children who have this condition, they will only use it up to the lowest level that the lab says is that anything above 0.8 levels are considered high, and they will not raise the dose. And most of these children need levels above 1 in my experience anyway, to actually see the efficacy. So there's likely a threshold for the drug working, and you have to get it up to a certain point, and it should be used as Bob was describing. He uses it, you really give it up as high as the person can tolerate without significant side effects, and don't worry so much about the serum level, because it's not, with real toxicity, if you were to develop it, you could get it at levels lower than 0.8. So it's really a strange conflation of negative press, and but unfortunately, like most information, it can hold sway and change the whole character of a treatment.
Yeah, and while we're on lithium for a second, this is a bit of a segue, but there's a new study in Lancet or Nature that just came out that turns out that people with mild cognitive impairment or Alzheimer's disease actually have a deficit of lithium in their brain. And when they made animals lithium deficient by giving them low lithium in the diet, they all had confusion and dementia-like behaviors, and that lithium reversed that. And remarkably, a version of lithium called lithium orotate was the best because lithium orotate didn't get involved in the plaques. So there's data. Demitri says that there are some data that regular lithium can help with mild cognitive impairment and maybe Alzheimer's as well. And now there needs to be new studies of how well lithium orotate is going to work.
So, Dr. Papolos, you started to talk about lithium levels and the importance of prescribing it to clinical response as opposed to some number on the rating scale that the lab gives back. Now, treatment with lithium is the beginning of the treatment protocol for TSDD, which you go into in detail in the paper. Could you walk us through what that protocol is in terms of treating TSDD psychopharmacologically?
Sure. So the protocol emerged from clinical observation, and we've first learned that unless you stabilize the mood cycling most reliably with lithium, nothing else held. So that was the first order of business, and getting up to as high levels as are tolerable without producing side effects are usually effective, most effective. After that, thermoregulation and sleep became the next critical targets, because once you stabilize the mood, it starts becoming very clear these other symptoms become primary symptoms. And it's like the mood swings are kind of occluding and obscuring what lies underneath. And those were the next, major targets. And as we learn more about thermoregulation, well, we found that there are pharmaceutical agents that some originally used for treating hypertension, like clonidine, for example, which essentially is a vasodilator and opens up blood vessels. So if the problem is you are not shifting the heat that's developing in your core as you go through the day, and your muscles are generating heat and your brain is generating a lot of heat, and you're not shifting it off fast enough into the periphery where it leaves as insensible, water loss, basically a sweat, you need to improve that process. And we release the heat through the blood vessels, basically, that are at the surface of the skin. And clonidine, for example, opens up those blood vessels so there's a wider circumference and more fluid basically can leave. And the other natural vasodilator is melatonin, which also has a profound effect. That is nature's way of basically saying, okay, it's dark outside, it's time to prepare to go to sleep. So those were, in terms of, let's say, pharmacological interventions, those were two that we started with, and we would give both immediate and extended release clonidine at the beginning of sleep, along with a physiological dose of melatonin. And by physiological dose, I mean no more than 2 milligrams. Most preparations that are sold in the United States are like 5, 10 milligram doses, and that is not a good idea because the melatonin receptors get saturated after a while, and so the effect is significantly reduced. Those are the pharmacological interventions, but if you want to cool the body, there are other ways of doing it that don't require medicines. And we eventually developed these both thermal cooling and ventilating. We didn't invent them, we began using them. So one thing that's important to know about thermoregulation is if you're not dissipating heat over the course of the day, you're the coldest you're going to be in the morning, because overnight you're not generating so much heat, and you're actually losing it. And the body goes through a process where it's dissipating more and more heat. And these kids actually become too cold in the morning, and that's why they have sleep inertia, where they can barely get up out of bed, and they're inattentive till middle of the day usually. And that's part of the thermoregulatory problem that they have. So, and then during the day, they start generating more and more heat. They're running, they're jumping, but they're not dissipating it fast enough. So they start overheating, and usually around late afternoon to early evening is the period where most parents will tell you these are where they see these aggressive outbursts, and and faces are flushed. Also in the late evening, ears are beet red because they are still overheated. And as I mentioned before, you cannot get to sleep if your core temperature is rising and not dropping. So one of the things we basically started doing is, in some cases, pharmacologically, we'd give extended release clonidine sometime around 1 o'clock in the afternoon, in addition to the nighttime dose. But cooling techniques work phenomenally well. And, there are a number of them which are listed on the JBRF website. There's a whole list of things and devices that you can use to help. But basically, most recent study, not related to this, but showed that the best way to lower core temperature is essentially to eat an ice slurry. So snow cones would be very effective, and are very effective in my experience, to getting core temperature down, because they're really getting into the gut, and you have a large surface area of ice that's cooling. We have been using that, and also full body immersion, baths. In lukewarm water are very effective in dissipating heat from the body. And we also recommend ventilation, because the more you ventilate, the faster the heat gets out of those blood vessels. And so you're basically providing an air conditioning system for the child, because their AC system doesn't work very well. So that, and most recently, as we've really begun to appreciate how sleep inertia is directly related to their being cold, and the poor regulation during the thermoregulation at night, using an electric blanket about 45 minutes, putting it on a timer and using the electric blanket to heat them up just as they are rising in the morning. And that clinically seems also to be another way of helping these children. So there are a number of non-pharmaceutical and effective methods for treating. I tell
Demitri, before we run out of time, can you go through the details of how you do the ketamine studies for someone who's kind of naive like me? What are some of the details about how you can do that in the clinic and in family practice?
Yeah. So basically, it's really kind of a custom way of treating with ketamine. First of all, we use racemic ketamine, which is what's been on the market for over 35 years, not this kind of jerry-rigged S-ketamine that is actually, according to studies, less effective than racemic ketamine, which is the general ketamine. So we go to a compounding pharmacy. They compound it if we're using intranasal, we usually use 100 milligrams per ml. You can't go above 150 milligrams per ml because the ketamine will crystallize out of solution. So usually 100 milligrams per ml is sufficient, and it's easy to use because one spray is 10 milligrams, 0.01 milligram in each spray. So you basically start, usually the first time, perhaps one spray in each nostril, 20 milligrams. Child is sitting down. We actually teach them a specific method for inhaling the ketamine, because ketamine has a nasty taste and it can easily go down the throat when you use it intranasally. So we have them teach them how to breathe by first blowing out the birthday candles with a very, very big breath, and then breathing in quickly through the nostril. And when they breathe in through the nostril, that's when the parent, sprays the ketamine, and that will usually keep the ketamine from going down the throat and getting it up into the nares where it gets into the central circulation, but also can actually piggyback up the olfactory nerve and go directly into the brain. So then we observe for side effects after 20 milligrams. 3-4 minutes later, ask them to stand up if they can, slowly walk around, find out whether they have any ataxia. Does it feel like they're walking on a boat? Do they have any kind of dissociative symptoms? And, if not, then we go up another 10 or 20 milligrams, 2 sprays.
How often do you wait before you
By
go?
10 minutes, 5-10 minutes.
Yeah, okay, thanks.
And then you get to a point where child starts seeing visual illusions. They're things that they're seeing. They have double vision. So the ketamine got into the brain, and you stop there because you don't want to go to dissociation. So they get that dose going forward every other day for usually 3 to 4 administrations. And then what happens typically is that they develop a tolerance for the side effects, and you can begin increasing it sometimes up by 10 or 20 milligrams. So this is iterative, you do this until you get up to whatever dose is effective and not producing intolerable side effects. And that's where you stay, basically.
So it sounds as though you're describing a very slow, intentional titration process that keeps the dose on any given administration below the point of dissociation and other types of potentially unpleasant side effects? And how do you know when you have reached the therapeutic level?
Well, yeah, that's very well said. That's exactly the principle. And we are before we start the ketamine, we have a set of specific symptoms, categories of symptoms, 8 or 9 categories that specify very specific symptoms that are part of the syndrome. And we ask parents to choose 8 of them that are most descriptive of their child at that moment in time and things that they think they can give an objective rating to. We put them into a template, and in that template, the parents score for 10 to 14 days prior to starting ketamine, so we have a baseline. So they'll have their scores, and then we'll start the ketamine, and they'll continue rating on a daily basis these specific symptoms. And when you get to the dose that's going to work for them, they basically really have very few symptoms. And
what's your typical interval between doses? Do you do most everybody every other day, or do you lengthen it out?
at this point, starting every other day, once you get to a therapeutic dose and it's been effective, and you can then start increasing the duration between dosing.
Thank you.
Mm-hmm.
I imagine it's difficult for parents at times to tell the difference between the symptoms that are related to the temperature dysregulation versus the symptoms that are related to the mood disruptions. And if you're tracking mood disruptive symptoms, such as irritability, for example, that may not necessarily be addressed through the ketamine, just as the overheating in the late afternoon isn't going to be addressed by the lithium. So how do you advise parents to differentiate between the sort of more classic bipolar disorder symptoms versus the temperature related ones so that they can be as accurate as possible with those 8 symptoms that they're tracking?
Well, if we're talking about the temperature, that's something that is, I mean, they've seen it since the kid was, in diapers, basically. They know, or before that, they know the child was really, really hot, and they've seen that for quite some time. So it's nothing new. They just never associated it with this behavioral symptoms that they have. So it's more a matter of teaching them that this is part of the syndrome and explaining to them why and how thermoregulation is so important in terms of the behavior they're seeing in their child. I mean, it sometimes takes months and months and months for me to get that across because it's so hard to believe. But once they get the idea, they begin to see the value of doing these things that I've been suggesting, like cooling techniques, et cetera. But I must say, it's a heavy lift to get that to be understood, and of course, even more so with clinicians.
Dr. Post, did you have another comment or question that you wanted to make on this topic of the ketamine administration?
Yeah, just in your experience, Demitri, have other psychiatrists who are not that experienced with ketamine, have they been able to pick this up and do it, or does one have to look for an anesthesiologist like you found in the beginning in order to do it? How does one really get to do the ketamine, and who's the best person for doing it?
Um, uh, we have to realize I have a certain, I mean, I have a referral practice and people come almost pretty much diagnosed by the time I see them, right? So And one of the reasons they come is because they've already read about the condition and they understand it, and they've tried to find clinicians. Before we get to the ketamine, the first step is diagnosing childhood onset bipolar disorder. That is, you don't get beyond that usually. Um, and so you have to, and so I have not found anybody except for people in research clinics who you probably know as well that will diagnose it. In clinical practice, pediatricians have been taught, nay, indoctrinated to believe that it doesn't exist, as I said before. That's the story I hear over and over again from parents. And I think, Elizabeth, you can probably, right?
Yeah, absolutely.
Yeah.
It's a Sisyphean task getting clinicians to recognize that bipolar can in fact occur in the pediatric population, and so it's something we work on every day.
So what I have realized is that the people that see children who are willing and interested in treating this syndrome are, for the most part, are advanced nurse practitioners. And that's the cadre of individuals that I think we need to begin to try to hopefully educate about this condition. Um, and in terms of the primary question about ketamine, that's a real bridge too far for child psychiatrists. I mean, lithium is a bridge too far, Bob. So forget about ketamine.
Yeah, but so will these nurse practitioners be able to do the ketamine, or who does one go to if they can't readily get to you?
Maybe Elizabeth, that would be a better question for Elizabeth, because I have the same experience over and over again. So
I mean, nurse practitioners, depending upon their state, can very often prescribe ketamine without oversight from a psychiatrist or other physician. And so they have the capacity to learn this treatment protocol and implement it. I think one of the things that is so useful about this treatment protocol is the degree to which it is measured, and it is careful, and it is slow titration, getting the patient to the point where they are using effectively the lowest possible dose necessary to get the job done of treating those symptoms. And so that can be done in a lot of outpatient settings where nurse practitioners and advanced practice psychiatric nurses are. And, there are a lot of nurse practitioners who actually work in ketamine clinics. And while we recognize that their bread and butter is in the infusions, those providers are also in a position to be able to prescribe the generic nasal spray or troches of ketamine and teach their patients how to use them safely at home, the way so many patients already do in treating this disorder.
When you say they have ketamine clinics, is that ketamine for anesthesia or ketamine for what?
Ketamine for treatment-resistant depression, ketamine for, mental health conditions.
Yeah.
So the infrastructure is already there. It's really a matter of getting the folks who are already working with ketamine to recognize the value to patients of this non-intravenous form of delivery through either intranasal spray or the sublingual troches.
Yeah.
And we have to remember that those clinics are primarily service adults, not
That's
primarily, exclusively, I think.
I suppose there's a gray area with what it constitutes an adult. Some will work with teenagers as low as 14. But that doesn't do a lot of good in helping the 9-year-olds who are in need of this treatment. So need. And what I'm hopeful that this event with you two will do is bring greater awareness to the community of practitioners that this is not only possible, but it is incredibly beneficial to a subset of patients who are oftentimes written off as being too complex, when in fact there's a simple, straightforward protocol for treating the illness and seeing tremendous symptom remission as a result.
Yeah, good point.
We have about 15 minutes left. So I want to check in to see if our audience has other questions about the medication treatment protocol that Dr. Papolos has described before we move on. So I'm going to scroll through here and see. Okay, so I want to double back for a second and ask you both to again talk a little bit about the ultradian cycling that happens in bipolar and in the TSDD phenotype, because it's very distinctive, and I believe it's easy for parents and teachers and other folks who work with kids to be able to identify it once they know what to look for. So can you talk a little bit about what to look for?
Yeah, it's usually pretty clear in terms of a kid or an adult having a period of time, like 15 minutes to a half hour of being profoundly down where they can hardly move or speak, looking terribly depressed, feeling suicidal, and then all of a sudden, without any stimulus, being up and euphoric and happy and talking, and that can also last 15 minutes to an hour or so, and then back down again. And how many times somebody goes up and down like that usually is multiple times in a day, but sometimes, as I said, 5 or 6 times a day, but it's pretty clear-cut mood shifts. And this lady that I saw who went up and down 5 times a day, she could go up into a euphoric mania, or she could go up into a hyperactive dysphoric uh, mania and not actually be euphoric. So it's profound depression switching into this energized state and then back down again. So we've seen that in a fair percentage of adults as well, but many of the kids with bipolar NOS present that way.
Dr. Papolos, did you have anything you wanted to add to that?
Yeah, I think it's important to think about these events as rhythmic, and that the ultradian or within the day moods swings are pretty much a common phenomena with these children, and they shift from irritability to euphoria, silly, giddy, goofy, and then into depression, and that can happen multiple times a day, as Bob mentioned. There's also a very specific diurnal variation that occurs usually in the late afternoon, and that is primarily thermoregulatory, and that has to do with this, peak of overheating, and that causing significant, what looks like mania, but is just really aggression, explosive aggression. So the how these we call them two different conditions, how they interact with each other are important, and important to think about how thermoregulation does. And then there is the seasonal mood disorder, which is quite profound for TSDD, where and very regular and very predictable, and that, which we haven't talked about. Using it proactively, like beginning at the end of August, blue wavelength light treatment to prevent the onset of the seasonal depression, and maintaining it throughout the winter is very important and very critical in terms of the long-term treatment.
So another question did come in about the ketamine protocol. And it was, what is the longest you have treated anyone diagnosed with this subtype with the ketamine protocol? And do symptoms reemerge if the ketamine is stopped?
Okay, so it's a good question. So as I mentioned before, I mean, it was over 20 years ago, the first patient was treated, and there have been, and she has graduated from college, living independently, and I have 3 or 4 others of similar, vintage. All going to college. One is just about to apply to medical school. Um, so now, in terms of how long are they on the drug? I mean, I try once somebody is stable for a number of years, really stable, and they have. I mean, I guess let me go back and say, I mean, I see this condition as really pernicious and interfering with all sorts of developmental tasks, particularly, I mean, very specifically relationships, because they are in a fight or flight mode all the time. And so their relationships are also essentially about dominance and submission. And that's all they could be under the circumstances. And to the extent that that goes on for any length of time, we're talking about behavioral conditioning that takes place. So, you have to take that into account as an important factor that's going on. And when they begin to actually have an awareness of their emotional life and their behavior, and they have an observing ego, and they start to develop relationships that are not in that mold. You know that you've basically changed a phenomena that could have gone in a very different direction. Um, and and so um, uh, when that starts to happen, that's when I will start to say, look, you've been on this for 3 or 4 years now at this dose. Why don't we try reducing or increasing the duration between doses? Well, that is very hard for them to accept because they know how bad it was and they know how well they're doing. And so it's a tussle to try to get them to begin to experiment with this medication that they see as really having been phenomenally effective. So,
If they're going to do that, do you leave them on the clonidine to continue to deal with the thermoregulatory problem?
oh yeah, oh yeah.
Okay.
And there are some cases where, and this is obviously would only have seen recently over the last few years, where they have come off, and the thermoregulatory problem has not reasserted itself. Now, this may have to do with ketamine's effect on BDNF, which is a gene that actually has a regulatory effect on thermoregulatory threshold. And my speculation is in those individuals, the long-term use of the drug has affected essentially their threshold, and they are more tolerant of the heat and less tolerant of the cold. And that's another sign. When I see that they are now putting, coats and hoodies on when they go outside, I know that there's been some change that's taken place, at a higher level in the brain. And that's another indicator of when to begin thinking about increasing the duration between dosing.
So we are closing in on the end of our time together today. Can you talk just for a moment about what research you see as being sort of next. What needs to continue to be done in investigating this unique illness?
Well, we need controlled trials of the full protocol, epidemiological studies to understand the prevalence and the course, biomarker validation, including temperature and sleep metrics, and mechanistic research looking at thermoregulatory circuits and fear circuitry and the effects of ketamine, clonidine, and lithium. So this implementation science is going to be crucial. So there are many questions that need to be asked and answered. And overall, the whole issue of the effect of thermoregulation on human behavior and how important that is in a whole variety of different areas that we really haven't thought about.
For those of you who may not know, Dr. Papolos is the author of the book, The Bipolar Child. Dr. Papolos, I understand you may have a new book coming out next year. Is that true?
Well, we can't predict when the timing, but there is a book in preparation but primarily describing the syndrome, its treatment, and the underlying biology.
Wonderful. Well, I want to thank you both for being here with us. This was a tremendous resource that you have made available through your time and expertise for the clinicians who were present today. Anything you want to say in summation? Any final words you want to leave our audience with about your paper, this protocol, or the incredibly important work of getting children diagnosed accurately and early?
Yeah, I just want to add that parents ought to get the saying in their head, treat them early and well, and protect the brain and body.
Okay.
I just want to say thank you for hosting this, Elizabeth, and it's been a pleasure. Bob, thank you for being part of this.
Yeah,
Yes.
thank you both. It's been very educational for me too.
Thank you again, Dr. Papolos, Dr. Post.
Keep up, Elizabeth, keep up all your good work. We need it.
Thank you, Bob. I appreciate that. We are here to help families and providers learn more about this disorder and how to access treatment. So please do not hesitate to reach out. You are not alone.